All right, I think we are live. Welcome to the April 2022 Smoking Cessation Professionals webinar for APSAD Smoking Cessation Professionals Interest Group. My slides are not moving forward for some reason. So James, can you see my slides all right now?
I can see your slides. They're
Yes.
just not in. They're just not in
the presentation mode.
Presentation
so yeah,
mode,
it's just not letting me do that for some reason. So I'm gonna just progress this so that we can move on to your presentation quickly. So welcome everyone for the APSAD Smoking Cessation Professionals webinar for April 2022. We would like to acknowledge the traditional owners of the land on which we and our events are located. We pay our respects to all elders, past, present, and future, and acknowledge Aboriginal and Torres Strait Islander people who may be joining us today. Just a little disclaimer before we start: the views expressed within this webinar are presenters' own and are not necessarily the views and opinions of APSAD. The Society does not accept responsibility for any information, research, recommendation, or advice contained herein. So today's topic is what have you got to lose? 5 risk-free behavior strategies to manage cravings and easy to teach. And our presenter is James McLennan. James is a registered psychologist with 20 years experience in the drug and alcohol field, specializing in tobacco cessation. He is the current New South Wales statewide tobacco cessation training coordinator. He has helped thousands of people quit smoking and trained people in tobacco cessation skills. It is estimated that he has assisted between 30 to 40,000 people trying to quit smoking. He is skilled at delivering meaningful behavioral change outcomes through the translation and utilization of evidence-based neuroscience. So thank you, James, for presenting today. And I'm now going to stop sharing my screen so you can have the go. Thanks.
Thanks very much, Dipali. I just want to make sure that you can hear me okay, Dipali? It's good. Okay. Bear with me, everyone. I'll just get our screen ready and up. And I'm assuming that's all good. We'll see that. Fantastic. That's great. Thanks for having me here today, and thanks for joining in. I think one of the things in the intro that I put, I'm not too sure we got around to it, is making these kinds of talks not boring. And you know, and look, I'm a clinician by trade, really, involved in a fair amount of research, but also coal-face work. And it's one of those things, isn't it, when you you know, when you're working with clients, you may take on board a lot of research information and a lot of academic literature, and then suddenly when we have clients in front of us, we may not be really sure whether some of this stuff's going to be realistic and practicable and doable. And sometimes we're caught between in this void between what may be best practice and what we can actually do in a realistic setting. So something a little bit different today, where we're going to learn 5 CBT type strategies that carry very little downside, and they're cheap, and they're or potentially cost-free as well. Things that we can teach our clients, and essentially they're designed. These are strategies that are suited to when the urge to smoke is emerging. In other words, the want. So not necessarily in drug and alcohol, we sometimes focus on the like, but what we're doing is focusing on that, what we call the incentive salientive cues, the wants, that emerging drive, that desire when you know, I've just got to have a smoke. Those kinds of that kind of thinking. So it's going to be short, punchy, and I'll deliver some of the strategies first. And, you know, and perhaps even today, what we can do is close our eyes and practice some of these strategies ourselves. And then I'll talk about some of the science behind these strategies as well, just to ensure that we're not talking hocus pocus. So here's strategy one. Strategy one is to have an alternative dopamine reward on hand. And really what I mean by that, and something that's practical and doable, and we've had a lot of success with, particularly in group behavior therapy programs, is to have a little snack handy. Now, in particular, glucose balls. Glucose balls. You might be thinking, James, what are you talking about? You know, this is just an unhealthy option. Hear me out on that. One of the positives of that is it's cheap, it's easy, and it's quite realistic. And one of the, perhaps one of the things that we've kept going in, particularly in group behavior therapy, is the humble lollipop. I have it here with me today, the humble lollipop. And we've had a lot of success in our clients, particularly disadvantaged clients, using the humble lollipop to help manage cravings at times when they feel like smoking. There are some concerns about weight gain. Sure, a lot of clinicians think, "Oh, look, I don't know if I should be doing this." Handing out sugary food. But the way in which perhaps myself and my colleagues look at it is, you know what? It's short-term medicine. It's short-term medicine to get through, in particular, that early part of quitting. So there are some concerns around that, and I think just pitching it as something around that, you know what? We're not going to be doing this forever. It's just for a few weeks. So some people have tried things like gum and nuts, and I think all of those are okay. But I do like the idea of a glucose ball or something related to that, particularly the lollipop. I like the lollipop because it's very tactile. Something in your hand, putting in your mouth, and getting that little dopamine hit. And in fact, I had a lovely story the other day when someone called me up who was working with a pregnant client, tried all the usual stuff, and tried NRT, wasn't working out. The humble lollipop was the thing that did it. Normally when they'd just be sitting outside, out the back, having a smoke, having a lollipop. So what's the science behind this? Is this just hocus pocus? No, it's not. Glucose tablets reduce cravings in newly abstinent smokers. We know this is the case, and there has been some work done around this, particularly by Robert West over at Cambridge in the UK. He's done some early work around this. And in fact, there has been some work when you attach glucose tablets, it may enhance the benefit of the patch or bupropion. The theory behind this, the thinking behind this is that newly abstinent smokers may interpret an increased hunger as a craving to smoke. There's this misinterpretation. So the idea is to have this little glucose treat to offset that urge that's skanking. We've known for some Australian work out of Queensland as well, is that administration of sugar changes alpha-4 beta-2 and alpha-6 beta-2 nicotinic acetylcholine receptors, the same receptors that nicotine attaches to, binds to in rat models. So there is method to the madness here. In a way, we pitch it as poor man's NRT. And look, we often get quite good response with our clients with something as humble as a lollipop, but you can try other things as well. It doesn't have to be that, but we do have some science at least that backs that. Now, strategy two. Strategy two is really about the idea that we start to see ourselves as a non-smoker on a quit attempt right from the get-go. So when we start to quit, even pre-quit, before we even get into quitting, we start to see ourselves as a non-smoker. And there's some skills and tricks that you can do with your clients that enable this to happen. So the idea here is to say to yourself, oh, look, I don't smoke. I'm a non-smoker. And just repeat that over and over again. I'm a non-smoker. I don't smoke. Now, I'll talk about the science with regards to this in a moment. But the way in which we would practice this in a one-on-one therapeutic session or in a group behavior therapy program would be something like this. And feel free to do it. Why not close your eyes? So there's two exercises here. The first exercise is this. You have your client close their eyes and they just imagine a smoker friend asking you to go outside for a smoke. And the client says in their own mind, self-talk, oh, look, I don't smoke. I'm a non-smoker. So that, the smoker friend's saying, oh, come on, mate, let's go outside for a smoke. And you have your role played in your own mind. Oh, no, I don't smoke. I'm a non-smoker. Really? Yeah, I don't smoke. That's the first way in which we can do this. The second way is to actually role play it with your clients. So, you can get a pen. I've got my fake cigarette here, which is, this one's an actually first generation electronic cigarette. But look, so the idea would be to say, Ryan, let's go outside for a smoke. And I'm offering the cigarette, and you say, oh, James, no, I don't smoke. I'm a non-smoker. Really? You're telling me you don't smoke? No, I don't smoke. And now you can do this even before someone gets into quitting, so the idea is even if they're still smoking, they start to instill this belief, this self-talk, this cognition that they start to see themselves as a non-smoker. Now, the positives of this, of course, is that it's easy to do. It's free, doesn't cost anything. But the negative, perhaps the downside, is you do need to practice this. And really, this is a key point with all of these strategies today. You have to practice them. So this is where you as a clinician comes into play, where there's a structured counselling environment or group behaviour therapy environment, for example. Certainly can be done in much more of a layman's way as well. However, the idea would be to practice it. It's a bit like sport, isn't it? It's a bit like sport. You practice midweek for game day Saturday. So the idea, we want to practice this in controlled environments, and when we get outside into the real world, in these kinds of environments, you put it to the test. So you do have to practice this. Now, we've known for some time that ex-smokers that make a mental transition to a non-smoker identity following a quit attempt are more likely to remain abstinent in the medium term. The work has been done around this. There's a number of pieces of work. Happy to share. By the way, happy to share any of these references with you today. So in fact, the self-talk language here is quite important. So in one piece of work where the self-talk language was manipulated a little bit, I don't, as opposed to I can't, ended up improving goal-directed behavior when faced with choice. And when we have choice between things that we can do, the self-talk language of I don't instead of I can't improves goal-directed behavior. Can't suggests kind of might want to do something, but you're denying yourself. Oh, I'm trying to stop coffee. Tell me if you haven't done this. I'm trying to stop coffee. I'm trying to cut down on my coffee. And you're saying, oh, I can't have it, but I want it. Oh, maybe we'll just have one today, start again tomorrow. You know what I mean there, don't you? But of course, don't suggest no leeway. It's an unbending rule. Let's think about this from this morning. Imagine if you were going for a cup of coffee this morning. There's a big difference, isn't there, between I can't have coffee, I can't have it, versus I don't drink coffee. I don't drink coffee. You see and you can see where this may come into play with our clients. Days, weeks, months down the track, a friend, you just bump into a friend, an old smoker friend, and they say, let's go outside for a smoke. Let's go down for a smoke. And there's a big difference between, oh, I'm trying to quit. I'm trying to quit. What does that really mean? If push comes to shove, if I really, 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 really want to have one, I'll allow myself to have one. Compare that to, I don't smoke. I'm a non-smoker. It's firm and it's an unbending rule. So there has been some work around this. And in fact, you might be thinking, I know where this is playing out, because if we look at a lot of pregnant women that smoke, there's sometimes this cognition of, well, it's temporary abstinence. I'm pregnant, I'm not going to smoke because I have this goal of protecting my unborn child and myself. However, when, it's still a temporary abstinence, feature in my life. And, when my baby is born, I'm just going to go back to smoking. And we see this in the data. So So you can see there that this idea of instilling this non-smoker identity can be very, very powerful technique long-term. So here's strategy 3. Imagine your personal worst case scenario. And the idea here is to develop a mental image of your own personal worst case scenario of continued smoking. I don't think it's ever a good idea too much to talk about yourself, but however, I just want to say this. This is how I did it. This is actually how I got across the line many, many, many years ago. And the idea here is to use your own imagination, a visualization, to get through cravings when you have nothing else at hand. And this can be a very, very powerful technique. One of the positives of this technique is that it's free, it's backed by sound research, but there are some negatives attached to it as well. In a way, this technique is what a lot of our clients would loosely call willpower. And they just kind of term it under this umbrella. It's fairly unstructured, but this is really a structured way of doing it. And it's, you know, it's a cognitive exercise, and the idea is to use your imagination, use your cognition to get through those difficult moments. So this is how we coach it. This is how we coach it. Now, just bear in mind with this technique, you can get some tears. You have to pick your moment. It's not going to be suitable to everyone, but it can be very powerful if you, particularly if you have that good, strong relationship with your clients. So this is a nice way of teaching it. Close your eyes. So if you're, I mean, you can do this yourself if you want, you know, just bear in mind that does carry potentially some emotional response here. So the idea is for the client to close their eyes, pretend you're watching your own life's movie on TV in front of you. Pretend you're watching your own life's movie. And there's a number of, you know, versions of this movie. And this version is one of continued smoking. So what I'd like you to do is pick up the remote control and fast forward it to later on in your life, and then hit the pause button. Hit the pause button. Now at the pause, you see yourself in the worst possible situation you could ever imagine seeing yourself in from you having continued smoking. Now, this is not what's on cigarette packets. This is not about someone else. This is about you, your own personal worst possible situation. It may have nothing to do with health. It may have something to do with money or something else, because it's about you. So when we're undertaking this exercise, it's a mindful exercise. We need some quiet time. We need concentration. We need visualization. What does it look like? Describe this image that you have in front of you. What does it look like? Who's in it? Tell me about who's in this image. What are the expressions on their faces of the people around you as they see you in this position? What are you thinking and feeling? What's the, you know, having a look at your expression? How do you look? What's your emotion here? What's going on here? And have your client describe this out loud to you. And this this can provoke quite emotional responses, which is not a bad thing, because that emotive response is something that's often powerful enough to offset the strength of cravings at the time. I remember many years ago running a workplace group behavior therapy program in this was actually a corporate place. Actually, this was a high-flying corporate place in the city, and everyone was up there, and some of these people didn't really want to be there, or fairly lowly motivated, which you often get in those kinds of programs. And I just remember this one girl down the end. She was just tears, rolling down her face. Picked up the cigarettes out of her bag, screwed it up, and just threw it across the table. That was a bit of a win. Of course, that doesn't predict cessation, but what it did, it gave her a tool for when she got out there in the real world, she could use this visualization to offset craving. So the idea is not to think about this more morbid set of circumstances all the time. It's really about doing it when the time comes, when you have to do it. Now, of course, one of the issues with this is that you have to practice. Some people struggle with developing imagery. It's not going to be for everyone. Some people get upset, but when it works well. Now, this has been put to the test, and Heidi Cobra over in the US has done some work around this. Not quite that example, It's kind of hard to set this up in, functional MRI scans. However, very similar experiment. And it's been replicated, by the way. This has been replicated a couple of times now, that Heidi Kober's work found that when people did this exercise, or at least a similar exercise, functional MRI scans showed an increase in activity in regions critical for setting goals and planning behavior, in particular the dorsolateral prefrontal cortex. And of course, an area well known to generate cravings, the ventral striatum, was inhibited. So it's kind of, one offset the other. So as there was an increase in the dorsolateral prefrontal cortex activity, you got this inhibition of the ventral striatum. And that subjectively turned into this. Self-reported cravings reduced substantially. Just by using our imagination, they reduced subjectively by 34%, which is a real win, because all we need is our own imagination to do it. Now, I'm certainly not saying this is going to get everyone across the line, but it's one little tool in the toolbox that some of our clients will benefit from. But the idea here is that you do need to coach it. And I think some more work needs to be done around these kinds of studies. For example, just anecdotally from my own experiences in running programs, is that females tend to be able to do it a lot better and get more of a response than males. But that's never been put to the test. We don't know about that in trials. But we do have some prelim data to show this stuff can be very powerful. You probably know this one very well, but it is very effective, and we can use it as a craving management tool. If you don't know about it, you will now. So if you do know about it, don't worry too much. Just hear me through on this. The idea is to use some of these metaphors, and in particular, the most famous one, or maybe not the most famous one, but it's up there, isn't it? Is to use the stray cat metaphor, saying to yourself, when you're out there in the real world and you get a craving, oh, hang on, there's the stray cat. And I know if I feed the stray cat, I'm just going to keep on smoking. If I don't feed the stray cat, the craving will eventually go. And the way in which we would practice this is to mindfully rehearse the metaphor when there's no craving. Then we can imagine the cat when the craving begins to arise. So the idea is in a counseling session, a therapeutic session, group behavior therapy, or even in a very brief intervention, you could do this. You could do this in an inpatient setting, really. And the idea is to have firstly just talk about the metaphor, the stray cat metaphor, but then have our clients sit and mindfully just think of the stray cat and knowing what happens, visualizing what happens when you feed it. And then what you can do is have our clients practice that out there in the real world. Sometimes what I've done in the past, and it has worked quite well, is to go out into, let's just say, for example, you're in a community, health center, is to go outside where someone may, on the edge of I'm hoping it's on the edge of the campus, away from the no smoking environment or policy of that environment. But on the edge of the campus is to practice with them, out there, visualizing the stray cat. So again, having that practice effect. It's free, it's easy. Yes, you do have to practice, but really what this stray cat metaphor stands for is something that I'm particularly interested in, which is, and I think that's where we've had a lot of success with our programs in the past, quite substantial success, is really that these metaphors are akin to the science of what we do, the complex science around incentive salience, so or motivational salience. So that want, not the like, but the want to smoke. It's that emotive response that we might get when we go to the supermarket just with the intention of buying milk and bread, and you're going to end up at the checkout there with something else. So it's very much akin to the science around that. And that is certain things, situations, moods become memory paired with smoking. And we know nicotine plays a huge role in this, binding to areas in our brain involved with learning and memory, ventral tegmental area, the nucleus accumbens, the amygdala, for example, all playing a role in incentivizing these cues or conditioning the stimuli. So they act as a strong memory prompt to smoke. So the idea here is that we practice not feeding the stray cat. The memory prompt fades, and then you get a decrease in the urge to smoke. And therefore, at least what we want is that self-regulation begins to improve. So we're using this exercise to increase self-regulation. There has been some work done around this. So we know that mindfulness training to accept cravings, and in particular metaphors practiced mindfully, specifically in smokers, have been shown to reduce the intensity of cravings and reduce smoking. So, you could, so there is some work around that. We need more work around this stuff. But nonetheless, when these studies are developed, you see some fairly decent results. We don't have much to lose with that one. So that can be very useful. Strategy 5, a distraction technique. But with this distraction technique, what we want to do is use a specific form of imagery. Now, there's 2 versions of this, and you can play out these 2 versions. The first version is easy to do. The second version is not so easy, but it's not so easy from a clinical point of view, probably not from a client's point of view. It's fairly straightforward. So what we've known about distraction techniques is that they've been around for a long time, haven't they? And often, in fact, there is some data around that, if you put people into functional MRI scans and you say, just talk yourself out of smoking, distraction is just a naturally popular technique. It's perhaps all that people can, think about, some kind of distraction technique when given a choice to manage cravings. And so with this strategy, the idea is to use an imagery distraction. And we've known, well, there is some work around this, that successful reduction in cravings has occurred where participants visualize something completely different to smoking. So nothing related to smoking. So when you get that urge to smoke, you have some vivid visual image, really colorful image straight in front of you. And the idea is, again, in a therapeutic setting, is to sit down and have our clients work through that. What would that look like? A couple of examples that have been shown to reduce cravings is having a vivid visual image. That's not so easy to say. Vivid visual image of being on a beach, yellow sand, white sand, blue sky, or cows grazing. So big black, white cows, and eating rich green grass, deep blue sky, something like that. And the idea is to have that snapshot of that image in your head. Now, sort of moving along from that kind of imagery is, if you really get stuck, you can kind of do a mild version of an aversion therapy, which is really just using an aversive image. And, something like vomiting or something like this, and the idea is that, and this is where you may feel uncomfortable. You think, I just can't do this with a client. This is just not going to work out. That's fine. But, a lot of you will be fine with this as well. And the idea is to, when you feel like having a smoke, visualize someone vomiting, visualize, treading in dog poo, that kind of thing, something like that, and have that vivid visual image and thinking about what that would smell like and so on. So the idea is to offset that craving to smoke with that vivid visual imagery. So the idea, again, of course, is to do this when there's no craving to smoke. It's free, it's easy. You haven't got much to lose by doing that. But of course, you need to maintain practice. Is there any sense to doing this at all? Well, yes, there is, because the theory around this is that vivid visual imagery overloads limited capacity working memory. So there's this working memory that's limited capacity. The idea is, if you overload it with vivid visual imagery, that it's competing with craving related memories. And there's quite a good paper around that. And happy to share that with you. We've also known for some time, haven't we? I think we all know about the renowned Stanford studies on marshmallows, children resisting cravings for marshmallows by naturally using different techniques, and distraction was one of those techniques, and successfully done by quite a lot of these children. That, in order to get the second reward of 2 marshmallows instead of 1, well, a couple of things they did. One was hide under the chair, so they couldn't see the marshmallow. We know out of sight, out of mind is a useful strategy. But also, some of these kids visualize the marshmallow as a pet, nothing to do with the food reward. It's something visually completely different. So the idea is to be able to delay gratification, improve self-regulation by shifting attention away from the reward or the reward trigger. So that's important. to be able to do that. So those vivid visual imagery techniques can work well. Aversive images, even those unrelated to smoking, completely unrelated to smoking. So not those smoking related nasty images that our clients often think about. Ones completely unrelated to smoking have been shown to reduce self-reported cravings. And we can see this in neuroimaging studies. And I'll show you an example of that in a moment. Functional MRI studies, particularly more recent ones, there's actually quite a growing body of work around this. Functional MRI studies show that brains increase signaling in areas involved in emotional regulation. For example, the lateral prefrontal cortex, when using distraction as a way of managing responses to cues. So this can work quite well. Here's a study from a few years ago that exposure to smoking cues on the left, you get, as you'd expect, an increase in cravings and activates, a craving component, the anterior cingulate cortex. They often work in conjunction. And I think the science around this, which I'm no expert, hasn't been defined to the area where we need it to be defined. There's a lot of areas that, of the cingulate cortex working together with other areas to generate cravings. But nonetheless, using some of these distraction techniques can reduce cravings by decreasing. So, the idea is to, use some of these distraction techniques and let's just see what happens in real time. This was a real-time study, for example, a 12-person real-time neurofeedback study where people were able to manipulate their thinking to reduce activity in that part of the brain, and self-reported cravings reduced. Amazing, isn't it? Of course, we don't have the beauty of doing that in a real-world setting, but it does serve a point that using some of these distraction techniques, a vivid visual imagery or an aversive image, can reduce cravings. And again, it's another piece or another tool in the toolbox. I did say there was going to be five strategies, but here's a bonus strategy. It's the free set of steak knives. Had to do it. And the idea, and really the idea is something that I remember, I spent, 7 to 8 years on the phones at the New South Wales quit line. And you often see this in drug and alcohol work, don't we? Where, but particularly with novice clinicians, and, it's understandable that, you may, have a plan of attack for the following week. This is how we're going to manage our circumstances, our triggers, and so on. And you give all of these ideas out, and our client comes back the next week, and it just doesn't happen. For a number of different reasons, it just doesn't happen. And often it's a case of, I'm living with a smoker. It's just too hard. I go into it saying, it's not going to. I'm going to not smoke, well, they're not going to smoke near me, or, they're going to remove the packets of cigarettes, or I'll get rid of the packet of cigarettes, whatever it might be, and it just doesn't work out. So the idea here is to ask, the client's partner or friend or family member to give an ironclad guarantee or a promise, an ironclad guarantee or a promise. They won't offer or provide a cigarette, even if asking for one. And that can be extended to all sorts of situations. It may not, it may not just be that. It could just be, look, Bill's smoking at home. I'm going to make a deal with him to not smoke in front of me, just to smoke outside. It just could be that, so it's about a realistic guarantee or promise. So how do we do it? Well, the client agrees with the plan. The client asks that risk person prior to any risky situation. So this is before we get into a risky situation. So I'd be saying, look, Dipali, will you promise me? Will you promise me you won't smoke or offer or provide with me with the smoke under any circumstances, even if I'm begging you for one? And, and of course you may say, yeah, and it just doesn't work out, but you may say yes, and you're going to stick with your word, and that's really important. So of course, this is cost-free, it's free, it's easy to do. It can be very effective, very, very effective. And it can help force abstinence when all of these other strategies aren't working out. You may have tried the NRT, it might be helping a bit. Perhaps you've worked on some of these other cognitive and behavioral strategies, and they're just not working out. But this idea is to put up a bit of a barrier between you and that risk person. And it can work very, very well. So, but the thing is, it has to be a guarantee. The other person has to either say, I guarantee it, I promise. You know, I've had people when I was a clinician at Quitline actually sign forms, you know, getting their risk person to sign a form saying, I promise I won't do it. I won't give my client a cigarette. And, you know, those kind of things can work quite well. I'll tell you a story here just very briefly. I remember a client a number of years ago in a group behavior therapy program, and he was a golf player, and he said, look, every time after the golf match, I'd sit down, have a beer and have a smoke. And each time I did that, I was going to go into this and I said I wasn't going to smoke, but of course, after a few drinks, I just had to have one. I had a smoke. Anyway, he came in the next week, the next session, and he said, I said, you know, I can't remember his name now, Bill, how did it go? He says, James, you owe me $300. I said, what? What do I owe you $300 for? He said, well, I spoke to my friend, my golfing friend. You know, I set up this agreement that he wouldn't give me a smoke, like you said, and he agreed to it. But I was so cranky. I so much wanted that smoke. I went outside and wrapped the golf club around the tree and broke the golf club. That was $300. So I said, well, you know, did you smoke? No, I didn't. Well, there you go. And he did go along to become a happy non-smoker. So you can see there could just be that little moment where these kinds of things can have a positive benefit. And of course, not every person is going to be willing. They're going to be thinking, oh, this is ridiculous. This is just going to, you know, I should be able to do this with my own willpower, so to speak, or, you know, just using NRT. Sure, maybe you can, but perhaps the way to pitch it is to see this as a safety net. This is all about being a safety net. If those things aren't working out, what have we got to lose? You know, the idea is setting up a safety net if these other strategies aren't working out. So it's not taking away those strategies, it's just adding to it. It's just adding a safety net. Yes, you could always find a workaround. And in fact, you can find a workaround with any of these strategies, really. You know, if push comes to shove, sure, just go out and buy a pack, sure. We get that. But the idea is to really make that a little bit harder in those circumstances. So we've known for some time that studies across many fields that participants that make a promise to do something, if you have someone that says, I promise I'll do it, and that they should live up to their word, they were much more likely to comply. And I'm absolutely certain that if I ask you to promise me something, it adds some impetus, doesn't it? That you're probably more likely to stick with it. If I promise something, I'm gonna stick to my word. And look, we've seen this in a number of different fields. Taxation, for example, some people are more likely to pay their tax if they promise to do it. And so that's quite interesting, isn't it? And look, just a very small tip, and I think some of us already know this, and we haven't been able to do this over the last few years because of COVID. But one thing that I think works really well, and I think where we've had a lot of success in the real world coalface setting. So, you know, so where we're trying to translate some of that really useful science and putting into practice, and often where it doesn't work out, where you can add benefit, is to ask our client to commit to doing it with a handshake. Now, of course, we haven't been able to do that over the last few years. However, I think it's something we're going to be able to get back into. And handshakes, or even the elbow touch, you know, have been, not the elbow touch, but certainly handshakes have been shown to increase cooperation. So just running through an example for you with all of this, if someone agrees to use the lollipops, what I wouldn't be doing, this is just the example. If someone said, look, will you give the lollipops a go to manage cravings, and, you know, where they might say yes, and they come back the next week and it just doesn't happen. Yeah, they're just not doing it. The way in which I would approach it would be something like, you know, Deepali, when can you go and get the, you know, when can you go? Are you happy to use it? Try the lollipops. Oh yeah, sure. I'm just speaking on your behalf here, Deepali. Sorry about that. Yeah, sure. Okay, so when can you get them? Have you got enough money for it? Yes, I do. You know, I get paid tomorrow and I can go, I'm fine to do that then. Okay, so when will you get it? And when will you start this? Oh, well, I can get it tomorrow, and you know, I can start it tonight. So that high risk situation we spoke about was at 5 o'clock, just after you just before you're going to start getting dinner, you'd have that smoke. Yes, it is. So can you have one then? And then can we report on it the next day? Is that something you agree to? Yeah, sure, I can do it then. And so you're serious about it. And then there's the handshake. Away we go. So we seal the deal. We're going to give it a go. And essentially what we're talking about here are the SMART goals, really. But often they're forgotten in these kind of situations, and we want these SMART goals, very specific, very time measured, and realistic as well. And we can give that a go. And I think you'll find some success there. In summary, I hope I haven't bored you today, but in summary, these cheap or free CBT or some, some of these are really acceptance and commitment therapy type strategies, can play a critical role in managing cravings as they arise. And these are supported by science. Then, we're not talking about really well set up trials here, randomized controlled trials of NRT and varenicline. I'm talking about that, but nonetheless, there's some fairly impressive science around some of these strategies. The trick is they require practice. You've got to practice these things. They're not foolproof, and they're not designed to independently make people stop smoking, but provide extra tools for success. I always suggest ask clients to commit to doing one or more of these via a handshake. Some of them are going to be realistic for clients, others won't be. Others you just think they're just not going to do this, and that's fine, but nonetheless, it's there amongst your repertoire of tools. So those strategies are the snack, the non-smoker identity, the worst case imagery, the stray cat, the distraction techniques, and we've got the colorful, vivid distraction or the aversive imagery, and of course the promise to do something. So we're setting up a barrier between the client and the risk person, if there is one. There may not be one, but in those circumstances, and they can all work very well. The ultimate goal, of course, is to reduce impulsivity and generate that greater self-regulation. And certainly there's abundance of work around there, really, that clearly demonstrates this to be an important ingredient for success with smoking cessation. There's a nice little study to read down there. I think you'll have access to the slides where you can look at that piece of work. Here endeth the lesson. Hopefully this has been okay for you on a Thursday afternoon. I'm going to hand this over to, I think I should stop sharing the screen. Is that right, Dipali? Or just keep that up there?
Summary. We can keep the summary screen on if you want.
Oh, hang on. What have I done there? There we go. Yep.
I will. Thank you so much, James. I think that was quite a eye-opening presentation for some of the tips and tricks. I would now open up to the panel, which we have Ryan, Courtney here as well, and we'll take some questions now. So James, the first question has come from Ihsan. He's asked, first of all, said, fantastic presentation. I've learned a lot already regarding strategy 1 with eating lollies, when the best to take in relation to fast-acting NRT. Eat lollies before pulsatile NRT or after, or as a complement, or add lollies when pulsatile NRT, not cutting it any other time. So it's really needing some advice with regards to the snack tip that you provided. Yeah, what a question. And I don't have a great answer for you either on that. I think it's going to be a pharmacist, like you can see here, see that. Yeah, is a pharmacist. Yeah. I'm not going to have a great answer for you on that. And I think it's going to be horses for courses, because I don't think we've got enough body of research around that to know for sure. And I think it'll be a case of picking your moments and I think you'll find that some people, because a lot of this stuff has really evolved around real world settings where we're looking at the individual set of circumstances, right down to that person, that individual. And it may well be that, so for example, you're just using the example where the client was smoking in the afternoon. The pregnant woman was smoking in the afternoon, and she used that lollipop. NRT just wasn't cutting
cutting it for her at all. It just wasn't working out where the lollipop was. So it may be a case of trial and error, I think. And certainly, as far as I'm aware, there's no body of work that's around that says one way or the other. So I think, you know, what you might have to do is just play it by ear with a lot of the clients, really. I mean, obviously the obvious goal is making sure we've dosed up enough with NRT, and that's, you know, we're managing cravings best we can that way. And then I think, you know, I think supplementary, certainly adding something like a glucose tablet or the lollipop, which is the one that we've had the most success with, you know, is the way to go. Maybe as well, some clients just find it hard to get their hands on the, you know, they're hard to get their hands on NRT, and in those situations, you know, or they can't afford it, but, you know, in those situations, or they should be able to afford it, but if they can't, you know, they can use the glucose tablets at those times as well. So I don't have a clear answer for you, Ishan. I think we won't have to get Ryan to set up a study on that.
And of course, there is the concept about NRT itself raising the blood glucose. So apparently, Renee has posted a comment as well before. It says nicotine acutely raises the blood sugar, so glucose jelly being lollipop, they just after a meal helps with the need to have that after a meal cigarette. So apparently there is some research on managing the postprandial hypoglycemia.
Yeah, I have heard of that, and I think Renee makes a very valid point there as well.
Yeah. Of course, we need to be careful with our diabetic patients, and we often have recommended sugar-free lollies, for example, to some patients as well. So the hard-boiled lollies they can get.
Yeah, we often get people also, you've just reminded me of something here, Dipali. You often get people asking, well, you know, my client's just not going to, I don't think it's a good idea. You know, my clients with diabetes, whatever, they're just not going to use, you know, a sort of a sugary lolly. Well, you know, that's where a lot of the science lies. And you know, can we try some of these other things? I always say, you know, like a sugar-free lolly or sugar-free gum, give it a go. I just don't know. And I personally haven't had a lot of success with those ones, because it's really about, you know, part of this is really about what we see in some of these animal models with nicotine, with sugar molecules binding to nicotinic acetylcholine receptors, particularly alpha 4 beta 2. So I think, you know, that's where a lot of the science lies. But I think, you know, there's that tactile component as well. So you can give it a go. I don't think there's any harm in that. I just haven't seen much success with, you know, with the boiled lollies. Some of you may have had some success with that. That's fine. But I think, you know, it's more about that little sugar component molecule that's doing its thing. I noticed that, oh, sorry, Dipali, you go. I know there's a couple of other questions there.
Go ahead.
Oh, no, I know Renee's sort of chipped in there as well and adding short exercise. Yeah, absolutely. And I think there's a whole, if you're not bored with this and if you want a part 2, there's a whole range of other things that I haven't covered today. There certainly are a range of other things around that, and certainly short bursts of exercise, you know, something that, that, yeah, we can look at in other talks, and, you know, certainly wouldn't have any argument against that as well. Yeah. I mean, the other thing I think with all of this is that we find that, you know, it's at the practical level with clients, is finding some of these tools and tricks that are realistic and doable, that they're really going to do, you know, because yeah, you could explain it and coach it and all of those things, but if it's just not going to happen, then in a way it's often, you know, it's not so much a pointless exercise, but it becomes difficult. So we've found these ones in particular are quite useful, particularly the visual imagery, the based on Haiti Kober's work. That stuff can work very well. Mel has asked, Mel, hi Mel. Hi Mel, if only you get one chance with a person, what would be the best bang for your buck with information, tips, suggestions, at a community? Oh, I see. So you're at a community event, you want to coach some of these things. Stray cat metaphor, can't go wrong. Easy, quick, sharp, people get it.
I think we will read the question because it may not come in the recording. The question is, if you only get one chance with a person, what would be the best bang for the buck with information, tips, suggestions, example at the community event, etc.?
Yeah. I think if I had one chance, it's a bit of a gamble, but it's probably a choice between a sugar hit, like dopamine hit, like a lollipop, or the stray cat metaphor. We've generally found, particularly disadvantaged clients, they really take hold of the stray cat metaphor. I don't know why that is, but yes, I mean, I'm not just talking disadvantage, I'm talking across the board, but certainly, it's been quite a powerful technique used by a lot of the clients that we work with, and it's, they've stuck with it. Often it's the first thing they talk about when you come back for a second session the next week. Did you feed the stray cat to Parley? Oh, cat. There were hundreds of them. And okay, well, we have to work on that. And so they certainly, take hold of that kind of strategy, Mel. So I'd choose either one of those.
Oh, that's good. And I think the stray cat was one of the ones that I really like as well. I'm definitely going to use that in my clinic. There is no more questions in the Q&A at the moment. I just had one question myself, wanted to ask you. So do you think we can use these strategies without any further training, James, or do we need to have, like, as a pharmacist, can I just start using them from what I have learned today?
Oh, I think so. Yeah, I think one of the beauty of these strategies is that they're, they're. I mean, I think everyone here today, hopefully I've explained them, fairly succinctly, but the idea is, they're fairly easy to learn, and I think to transfer to your clients. So I think just start using them. I was always a little bit worried around the visualization exercise, the morbid visualization exercise, that may have some impact on mental health with those with severe mental illness, particularly major depression. Look, there's no data around that, but I have certainly checked this out with some very very smart people working in the field who are deep in this field, and there does not seem to be any concern with that whatsoever. I don't think you'll have any problems with that. So I think that's the only one where you may have some concern, but certainly we've never seen that anywhere. So I think just go forth and conquer, really, with these strategies, and hopefully they'll be helpful for your clients.
And just a question from me, James. I mean, as you said, there's abundance of probably strategies, but I guess you could call this as James's big six. But did you put him in any order for a reason? And what else would you add to it? A few of the things that I've experienced with some qualitative work with low-income smokers is also they've said things about stigma and also about rural setting as well. I know you touched upon that, out of sight, out of mind, but what would you add to this list, and just some brief explanation of why you went from 1 to 6 in that order?
Yeah, so probably the reason why I went with those in that order is probably what we've had, and I know this is not very scientific at all, but what we've noticed that's been the most impactful in a real world setting. So when we've tried them out, when we've gone and done these in a therapeutic sense, when we've run group behavior therapy programs, and I've run them, for a long time, these are the ones that I think that have stood out.
Yeah. So
and they're realistic as well, I think.
Yeah. So connectedness and buy-in and understanding. I think you also touched upon low cost as well.
Yeah.
And
brief. Yeah, low cost. Well. Connectiveness is a nice way of putting it, I think.
Yeah.
Yeah.
Okay. Yeah.
Yeah.
And then any thoughts? I mean, there's an era now where we live where, obesity is on the increase and healthy living is the way to go. It, always has been a preventative health strategy, but what do we do with, healthier alternatives than sugar? Is there anything that we can suggest? I know I've had some qualitative work where smokers have said that they've, their counsellor said to use a carrot, but they just said it just didn't apply to them. I'm not going to eat a carrot, So what do you do in the clinical setting like that to, you've already got a patient that may have diabetes and a bit overweight as it is. How do you grapple with that? Or do you go, it's okay, first things first, let's get cessation from cigarettes and then work on the next thing? Or how do you piecemeal that?
Yeah, I mean, I think particularly the sugar one, if we're focus on that. I mean, we certainly don't want some kind of transfer dependence. So we're not kind of looking at just swapping one for the other. And I think one of the pictures that I always make is this is short-term medicine. You know, we're talking about getting through that first 2 weeks in particular where those relapse rates are really high. So I think we want to view it for ourselves as a clinician and our client that this is very much a short-term strategy to offset, or you know, if we're going to fill that void where that you know, I enjoy smoking used to be, then it has to be pretty powerful. And so sometimes I think using, you know, like the sugar molecule is not too bad, but as long as it's short term. Now, if it's at a point where, look, it's just for clinical reasons, or the clinician or the client just refuses to do it, I think one of the beauties of these strategies is you just don't do it. Just move on to another strategy. It doesn't have to be used. So I think that's what we normally do, is just opt out of it. But you know, on most occasions, we've generally found most people are happy to use it and use it short term. I generally find if people build up a few weeks without smoking, you know, they can generally find that they know when to stop these things, or at least reduce them. They don't have a problem in doing that. I'm talking about the sugar components here.
Yeah.
So one, I don't think we don't want transfer dependence. We don't want to sort of transfer this over into you know, eating lollipops, 12 lollipops a day. You know, I don't think that's a good idea. But my view has always been anything to get through not smoking for a couple of weeks. Let's just do it. That doesn't have so much downside, and I think all of these strategies fall into that category. All
right. Well, we're pretty much at the very close on the hour now, James. On behalf of APSAD and the wider group and all the participants today, I'd like to send a big thank you for, you know, really giving some applied knowledge and understanding and deciphering some of the research to allow us to apply some very low cost, quick and easy and implementable approaches that, as we said before, have had great buy-in and connectedness with the thousands of smokers that you've helped over many, many years. So without anything else from my end, unless you wanted to leave any final comments, just a big thank you, James, on behalf of me and Dipali.
Thanks for having me today. I look forward to meeting some of you again in the future.
Very welcome. Thank you so much, James. Take care, everyone.
Thanks, everyone. Bye.
Bye now. Bye.